1-liter bag of normal saline. Put the irrigation line into the endoscopy pump and close the pump head. Prime the pump, then set the pump to deliver 30 cc's of saline per minute. Proper irrigation and aspiration are crucial to keeping the endoscope's tip and the disc cool. This picture shows you the path of the saline. If the working channel becomes blocked, the aspiration and cooling will be compromised. If the laser fiber is buried in tissue, the tip can easily overheat. Cooling with proper irrigation and aspiration is crucial for the safety of the case. Connect the laser fiber to the laser this way. Position the endoscope and slide it through the working channel. Sliding the endoscope through the working channel, you see the working channel walls, then the disc. The laser fiber is at the 9 o'clock position. Rotate the image connector to reposition it to the 3 o'clock position if you want up on the endoscope to correspond to up on the television monitor. Turn on the red aiming beam. It makes the laser fiber much more visible. Set the laser energy. Many physicians start at 1.4 joules per pulse at 10 pulses per second, or 14 watts. Later in the case, after you have established a cavity, you might increase the pulse energy to 2 joules per pulse at 15 pulses per second, or 30 watts. You need to choose an energy that works safely for the individual patient. Fire the laser, gently advancing the endoscope. Rotate the endoscope to enlarge the opening. Keep the tip of the laser fiber in view. For much of the case, you will simply be advancing and retracting the laser fiber, rotating it to reach different quadrants. While you move back and forth, rotating, you might be concerned that the cavity does not seem to be enlarging. You get this perception because, as you vaporize nucleus pulposus from the disc center, more nuclear material herniates itself into the cavity. This process will continue for most of the case. When you have vaporized most of the surplus nucleus, the cavity will finally begin to enlarge, and you can begin to deflect the endoscope. Deflecting the endoscope tip is reserved for later in the case. Whenever deflecting, be sure not to pull the endoscope back, as the working channel's distal edge can shear off its tip. Even a small cut in the endoscope shaft can cause a leak, seriously compromising the flow of irrigant and cooling to the endoscope tip. Your goal with the laser is to create a cavity shaped like a piece of pie. The apex of the cavity is the distal end of the working channel. The cavity should be widest in the axial plane and narrowest in the cephalid-chordal direction. The HOMI-YAG laser light only travels a short distance in water. That's why this laser is so good for discectomy. Almost all the light is absorbed completely within 2 millimeters. While this short range adds to laser safety, it does present a difficulty. The laser fiber tip needs to be in contact or near contact with the disc for it to ablate. If you're firing and nothing seems to be happening, consider advancing the laser fiber. There are 2 ways to do this. 1, just move the endoscope forward. 2, you can turn the laser fiber advancement knob at the rear of the laser endoscope handle clockwise. Using this knob, you can position the laser fiber from 1 to 6 millimeters from the endoscope's distal end. Remember that the distal end of the endoscope is radio-opaque, so on fluoro the laser fiber can extend up to an additional 6 millimeters. Don't bury the laser fiber in tissue. That can lead to overheating. To determine the endpoint of the procedure, consider both the total energy delivered and the appearance of the disc cavity. Most physicians deliver at least 15 kilojoules of energy, but there are no rules that can be applied to all patients. Ask the laser operator to report delivered energy every kilojoule. The appearance of the disc cavity can also be a useful guide to identify the endpoint. Early in the case, the cavity will collapse as you withdraw the endoscope, but towards the end it will begin to stay open. Some physicians turn off the laser and the irrigation, then watch the cavity as the patient coughs. If the cavity closes up, you should probably start lasing again. Don't forget to turn on the pump. Proper irrigation and aspiration are crucial. Withdrawing for the last time, you see the working channel walls, and outside the body you see the jet of irrigant. Withdraw the working channel. Some doctors inject an antibiotic into the disc and the tract through the working channel as they withdraw the working channel. Close the wound. Using an oversized dressing will help remind the patient that, no matter how good they feel, they have just undergone a discectomy. Performing a lase case is not difficult. You use the guide needle, working channel, dilator, and trephine to position the lase endoscope into the nucleus. Under constant endoscopic control, you use the built-in laser fiber to vaporize the nucleus pulposus. Constant irrigation and aspiration help keep the disc cool. You can determine the location of the endoscope's tip at any time using fluoro. Learning how to do lase helps you to provide a definitive, minimally invasive therapy to your patients. Your patients will appreciate your efforts. Learn more about lase at our website or by attending a lase preceptorship.